Yeah, so I started my practice at WashU in 2016 and have been doing lymphoma work for a few years before then. But even in that short time, the treatment has evolved significantly. There's over 90 different types of lymphoma, so each of these is treated somewhat differently. But just in the field of diffuse large B-cell lymphoma, where 7 years ago we used to give chemotherapy, and if people were not in remission, give more chemotherapy and consider an auto transplant. These patients are being moved to CAR T cells and earlier lines of therapy as they're FDA approved in that space. And one of the major questions remains where best to fit other immune-based strategies for diffuse large B-cell lymphoma, including bispecific antibodies. So I think, in diffuse large B-cell lymphoma, some of the major changes that we would anticipate seeing and having things evolved is earlier markers of progression of disease, or earlier markers of lack of response to therapy. In particular, there are many studies looking at the use of minimal residual disease assays to help determine how patients may do long-term with their therapy and which patients need to be escalated from their therapy. And then one of the, in Hodgkin's lymphoma, there's been a major paradigm shift in the treatment of Hodgkin lymphoma in the last 7 years, with the advent of brentuximab AVD showing the superior overall survival for advanced stage patients. This has become the standard of care from ABVD, which had been the standard for many decades. And with this comes the question about how to treat patients in the second line setting. Recent studies of using checkpoint inhibitors in combination with chemotherapy have shown significant response rates and high complete remission rates and have been tolerable. One of these studies was a study published by Alison Moskowitz recently of pembro-GVD in patients who had relapsed or refractory Hodgkin lymphoma, resulting in a complete remission rate of above 85%. Which was very remarkable. And that strategy doesn't use brentuximab, which is now commonly being employed for patients in their frontline setting. Similarly, there are multiple studies looking at checkpoint inhibitors plus other chemotherapy in Hodgkin lymphoma in the second line setting, and other studies looking at checkpoint inhibitors in combination with brentuximab, which was a subject of a US intergroup study that's to be resulted. So big shifts in Hodgkin lymphoma, where fortunately our patients are doing a lot better over time. Some of the major changes we've seen in peripheral T-cell lymphoma is also the advent of CD30-directed therapy, so brentuximab in the frontline setting. It's really become the standard of care for patients with anaplastic large cell lymphoma, where the addition of brentuximab to CHOP-based therapy showed an overall survival benefit. That data is now a number of years old, and the 5-year follow-up of that study has now been published of Echelon 2. And that really was the first study in T-cell lymphoma ever to show a survival benefit, making it very important and a proof of principle for development of further therapies and studies in T-cell lymphoma. And in cutaneous T-cell lymphoma, yet another completely different disease and different arena, major shifts have included the approval of drugs like mogamulizumab and the approval of brentuximab in that space as well, for diseases which are rare and often difficult to treat. And then in mantle cell lymphoma, yet again, treated quite differently than some of the other forms of B-cell lymphomas. The paradigm, even when I was a fellow, was to treat patients with CHOP and then an Ara-C-based therapy, consolidate them with an auto transplant, and do maintenance rituximab thereafterwards for 3 years. And those studies have shown, sequential studies have shown benefit to each of those measures, the addition of Ara-C, the addition of auto transplant, and then the addition of maintenance. And we had stacked one on top of the other. As people have developed more effective therapies that specifically work well in mantle cell lymphoma, the paradigm is all being questioned now, which is very exciting to see that maybe there will be a world where we're able to develop and give patients less toxic therapies with equally good, if not better, outcomes. I think there are lots of exciting areas of development. One of those arenas is in the area of bispecific antibodies for a number of different lymphomas, including follicular lymphoma, mantle cell lymphoma, diffuse large B-cell lymphoma, suggesting that these therapies may be able to harness the immune system to kill the cancer, but with less toxicity and not requiring inpatient hospitalizations like CAR T cells, and a low rate of cytokine release syndrome, hopefully making these therapies available to patients outside of large cities or large academic centers, which is certainly an area of unmet need. And so I think the use of bispecific antibodies, some of these have already filed for FDA approval, is likely to change yet again the paradigm for the treatment of many types of B-cell lymphomas. And then the question will be how to sequence them best, with multiple studies looking at using bispecific antibodies earlier in lines of therapy in the front line and the second line and in combination. So I think that will be a big improvement in the ability to care for these patients, hopefully with the ability to give time-limited therapy for patients who have lymphoma in the relapsed or refractory setting at least. So I think that's one of the major areas of development. In the arena of T-cell lymphomas, which I'm particularly passionate about, there are multiple drugs being studied in the relapsed refractory setting that seem to have overall response rates that are better than what's historically known with the currently approved and available drugs. These include PI3 kinase inhibitors, and early data for EZH2 inhibitors from the phase 1 study also look very promising. And so I think those are very exciting developments in T-cell lymphoma as well. We're doing a US intergroup study to look at the use of PI3 kinase inhibitors, specifically duvelisib, with CHOP-CHOP chemotherapy compared to CC486, which is oral azacitidine with CHOP-CHOP chemotherapy, compared to CHOP-CHOP chemotherapy alone in the patients who would not have qualified for echelon 2. So these patients have CD30 lower expressing or negative peripheral T-cell lymphomas, hoping that this group of patients who have a usual 5-year survival of 20 to 30% may benefit from more directed therapy or targeted therapy, and that this may ultimately improve the outcomes for these patients.